Diseases of the dental pulp. For there was never yet a philosopher who could endure the toothache patiently. William Shakespeare, Much Ado About Nothing, Act V. 4. The pulp is the formative organ of the tooth. It builds primary dentin during the development of the tooth, secondary dentin after tooth eruption, and reparative dentin in response to stimulation as long as the odontoblasts remain intact, Fig 4.1a and 4.1b. The pulp has been described as a highly resistant organ and as an organ with little resistance or healing ability. Its resistance depends on cellular activity, nutritional supply, age, and other metabolic and physiologic parameters. This variability has led to the remark that some pulps will die if you look crossly at them, while others can't be killed with an axe. On the whole, the resistance of the pulp to injury is slight in certain cases, but evidence of unusual persistence of vitality following injury has also been observed. Accurate pulpal diagnosis is the key to all endodontic treatments. Unfortunately, there has been a poor correlation between the clinical symptoms and the histopathology of the pulp. Previous attempts that have been made to diagnose the condition of the pulp based on clinical signs, or symptoms, electric pulp test, and or thermal tests and radiography have not always been successful. The endodontist is expected to understand the various causative factors of pulpal diseases, collect information about the presentation and history of symptoms, and conduct many practical tests before formulating the final diagnosis. Clinical note: the value of the pulp as an integral part of the tooth, both anatomic and functional, should be recognized and every effort made to conserve it. Causes of pulp disease. The causes of pulp disease are physical, chemical, and bacterial. They may be grouped as given in box 4.1. Physical causes. Physical causes include mechanical or thermal injuries. Mechanical injuries. These injuries are usually due to either trauma or pathologic wear of teeth. Trauma. Traumatic injury may or may not be accompanied by fracture of the crown or root. Trauma is less frequently the cause of pulp injury in adults than in children. Traumatic injury of the pulp may be due to the following reasons: a violent blow to the tooth during a fight, sports, automobile accident, or household accident, Fig 4.2. Habits such as opening bobby pins with the teeth and nail biting, Fig 4.3, that may also cause pulpal injury. Causes of pulp disease. 1. Physical, A. Mechanical, I. Trauma accidental, contact sports, iatrogenic dental procedures, during cavity or crown preparation, 2. Pathologic wear, attrition, abrasion, etc. 3. Crack through body of tooth, crown originating fracture, 4. Barometric changes, periodontalgia, B. Thermal, I. Heat from tooth preparation, at either low or high speed, 2. Exothermic heat from the setting of cement, 3. Conduction of heat and cold through deep fillings without a protective base, 4. Frictional heat caused by polishing or restoration, C. Electrical, galvanic current from dissimilar metallic fillings, 2. Chemical, A. Phosphoric acid, acrylic monomer, etc. B. Erosion, acids, 3. Bacterial, A. Toxins associated with caries, B. Direct invasion of pulp from caries or trauma, C. Microbial colonization in the pulp by blood-borne microorganisms, anachoresis. Box 4.1. Grossman binder. In 53 October 11, 2020, 12:50. 2. Pathologic wear. The pulp may also become exposed or nearly exposed by pathologic wear of the teeth from any of the following: attrition, Fig 4.4a and 4.4b, abrasion, Fig 4.5, bruxism, Fig 4.6, abfraction. If secondary dentin is not deposited rapidly enough, occlusal trauma may also injure the pulp because of repeated irritation to the neurovascular bundle in the periradicular area. In addition, certain dental
₹100 तक के
procedures
आसपास तो
occasionally
आराम
injure
से
the pulp.
निकल जाता है।
Some are avoidable, others are not. The iatrogenic
₹100 को
causes of
खरीद लो,
dental injuries
120
include the
25
following:
आराम से मिल जाएगी।
accidental exposure of the pulp during excavation of carious tooth structure to rapid movement of teeth during orthodontic treatment. Pulp. Nerve. 56 Grossman's endodontic practice. Heat from tooth preparation. Tooth preparation also produces temperature changes, with an increase of 20 degrees Celsius in temperature during dry tooth preparation 1 mm from the pulp and a 30 degrees Celsius increase 0.5 mm from the pulp. The sensation of pain, a warning signal that the pulp is endangered, is a protective reaction, as it is elsewhere in the body. The chief offender is heat developed by a tungsten carbide burr or diamond during tooth preparation. High-speed tungsten carbide burrs or diamonds may reduce the operating time but may also accelerate pulp death if used without a coolant. The heat generated may be sufficient to cause irreparable pulp damage. Special care must be exercised when the preparation is large, or when the tooth is being prepared for a full coverage crown, because cutting of dentin is extensive and many dentinal tubules are exposed. Evidence suggests that pulpal damage is repaired more rapidly when tooth preparation is done under a water spray. When a preparation is prepared with an air turbine and water spray, the pulp shows little or no response to the cutting. The dentinal tubules remain open or are unaffected for a longer period of time. In comparison with preparation at low speed, it takes longer for reparative or secondary dentin to develop, if it develops at all. Extensive research studies on high-speed preparation have shown that the stream of water or air, water spray must be directed onto the cutting surface of the burr for maximum cooling. The water stream is deflected in a centripetal direction by the rotation of the burr. Burns in the dentin may occur from overheating because of malfunction of the water spray or stream, with a corresponding reaction in the pulp. Aspiration of odontoblast nuclei occurs with inadequate water spray. Dry tooth preparation causes not only burns in dentin but also migration of odontoblasts, migration of erythrocytes, and hyperemia of the pulp. It was found experimentally that the greater the length of time the dentin was dried, the greater was the severity of odontoblast displacement. Clinical note: studies of sound human teeth in which tooth preparations were done at 200,000 rpm or higher with an air turbine, with adequate water cooling of the tooth, showed less injury to the pulp tissue than when cavities were prepared at speeds between 6,000 and 20,000 rpm, without a coolant. Damage and abscess formation of the pulp occur when a water spray is not used. 2. Heat conduction by fillings. Metallic fillings close to the pulp without an intermediate cement base may conduct temperature changes rapidly to the pulp and may eventually cause irreversible changes. Sudden changes in temperature from foodstuffs, such as eating ice cream, drinking coffee, or chewing ice cubes, may also contribute to pulp injury. Clinical note: remaining dentin thickness, RDT, under the restoration, Fig 4.7, is the key factor which would determine whether the pulpal changes would be reversible or irreversible in nature. 3. Frictional heat during polishing. Enough heat may also be generated during polishing of a filling, Fig 4.8, or during setting of cement to cause at least a transient pulp injury. These injuries are usually reversible in nature. Clinical note: the pulp responds to hot and cold stimuli that are perceived only as pain. Heat at temperatures between 60 degrees Fahrenheit 16 degrees Celsius and 130 degrees Fahrenheit 55 degrees Celsius when applied directly to an intact tooth surface is usually well tolerated by the pulp, but foodstuffs and beverages above and below this temperature range can also be endured. Figure 4.7 cross-section of a tooth restored with amalgam showing varying remaining dentin thickness, RDT, at different levels of the pulpal floor. Figure 4.8 polishing procedures might cause a transient and reversible damage to the pulp and must be executed properly. Grossman binder. In 56 October 11, 2020, 12:50 and 2 seconds. Chapter 4 Diseases of the Dental Pulp 57. 2 Chemicals. Chemical causes of pulp injury are probably the least common. The key factors which determine the pulpal reaction to a restorative filling material are as follows: acidity, pH of the material, heat generated during the setting reaction, absorption of water during the setting reaction, remaining dentin thickness, RDT, poor marginal adaptation of the material which might contribute to bacterial leakage. Fillings made of silver amalgam, or composites, may produce some pulpal reaction when they are inserted in cavities with very less RDT. The deeper the cavity, the greater the damage caused, but in most cases the pulp recovers from these injuries. Clinical note: the long-term prognosis of a restorative filling would be determined by its ability to inhibit microleakage and pulpal bacterial contamination. 3 Bacteria. In 1894, W.D. Miller suggested that bacteria were a possible cause of inflammation in the pulp. The most common cause of pulp injury is bacterial. Bacteria or their products may enter the pulp through a break in the dentin, from caries, or accidental exposure, from developmental grooves, Figs 4.9 and 4.10, from percolation around a restoration, from extension of infection, from the gingiva, or by way of the blood. Microorganisms play an important role in the genesis of pulpal disease, Fig 4.11. Despite food impaction, dentinal bridging occurs in the pulps of non-abiotic, germ-free, rats after pulp exposure. On the other hand, pulpal necrosis, abscess formation, and granulomas develop in exposed pulps of rats kept under ordinary laboratory conditions. The species of bacteria recovered from inflamed or infected pulps are many and varied. Although lactobacilli, acidogenic organisms, are commonly found in carious dentin, they are seldom recovered from the pulp because of their low degree of invasiveness. Microorganisms need not be present in the pulp to produce inflammation. The byproducts of bacteria in the dentin may be sufficiently irritating to cause an inflammatory reaction. The bacteria most often recovered from infected vital pulps are Streptococci and Staphylococci, but many other microorganisms including anaerobes have also been isolated. With the introduction of improved methods of molecular identification of pathogens, many new organisms have been identified by researchers. Species that have been found significantly include Porphyromitis gingivalis, Porphyromitis endodontalis, Fusobacterium nucleatum, and others. Polymerase chain reaction, PCR, methods show higher prevalence of Figure 4.9. Developmental palatogingival groove in maxillary lateral incisor acts as a pathway for carious invasion of the pulp space. Figure 4.10 radiographic evidence of pulpal involvement along with periradicular changes. Figure 4.11 mandibular molar with clinical evidence of carious pulpal exposure. Grossman binder. In 57 October 11, 2020, 12:50 and 3 seconds. 58 Grossman's endodontic practice. Treponema denticola, a recognized periodontal pathogen, in association with Tannarella forsythia and P. gingivalis. Clinical note: the presence or absence of bacterial irritation is the determining factor in pulp survival once the pulp has been mechanically exposed. Once bacteria have invaded the pulp, the damage is almost always irreparable. Reaction of the pulp to bacterial invasion. One should consider the mechanism of pulp injury and the resulting changes. Once the pulp is exposed by caries or trauma, it is considered infected because microorganisms gain access to it almost immediately. The invading bacteria, however, may be confined entirely to the small area of pulp exposure. At first, the infection is localized to a small area of the pulp, just as infection following a scratch of the arm is localized. Although the coronal area of the pulp may be involved by a mild or even severe infective process, the body and apical portion of the pulp may remain normal. The reaction of the pulp in the involved area is an inflammatory response. Polymorphonuclear leukocytes reach the area, and further dissemination of bacteria deeper into the pulp is prevented. Because some microorganisms enter the dentinal tubules, they may gain a foothold that is difficult to dislodge. In this respect, injury of the pulp and injury of the arm or some other parts of the body differ. In the latter, microorganisms are more readily reached by tissue defenses. The reaction in an inflamed pulp also differs from that in an inflamed arm or other organ in that little or no room is provided during the inflammatory state for swelling of the pulp because the pulp is entirely enclosed in a hard, unyielding dentinal wall, except at the apical foramen. If the inflammatory process is severe, it will extend deeper into the pulp and all the symptoms of an acute reaction will be manifested. Considerable inflammatory exudate accumulates and causes pain from pressure on the nerve endings. Areas of necrosis develop, owing to disturbance in nutritional supply. Many of the polymorphonuclear leukocytes die, and pus forms, further irritating the nerve cells. If the process is less severe, lymphocytes and plasma cells will replace the polymorphonuclear leukocytes in numbers, and the inflammatory reaction may be confined to the surface of the pulp. Such a chronic inflammatory state may be localized for a long time unless the microorganisms penetrate deeper into the pulp and cause an acute reaction manifested by a clinical flare-up. On the other hand, the chronic process may continue until most of or all the pulp is involved, ultimately leading to its death. In the course of this development, the organisms may be killed, but more commonly they survive and set up a recession in the periapical tissue by their products of metabolism. During the inflammatory reaction, tissue pressure is increased. Stasis occurs with resulting necrosis of the pulp. In some cases, the necrotic but sterile pulp tissue causes no symptoms and remains quiescent for years. This situation is an exception, because in most cases the microorganisms survive, and if virulent, multiply rapidly and reach the periapical tissue, where they continue their destruction and produce an acute alveolar abscess. If they are less virulent, the microorganisms will remain in the root canal and, by their toxic products, will gradually and quietly produce a chronic abscess without giving rise to subjective symptoms other than those associated with the sinus tract, if one develops. When the defensive forces of the periradicular tissues are adequate, a ring of granulation tissue is formed to delimit the bacteria and neutralize their toxins. In some cases, such low-grade irritation stimulates the epithelial rests and causes a cyst. Meanwhile, during this process, the dentinal tubules may become infiltrated with products of blood decomposition, bacteria, and, occasionally, food debris, and the dentin becomes discolored. Fig 4.12. Such discoloration of tooth structure is sometimes the first clinical sign that the pulp has died. Diseases of the pulp. Inflammatory diseases of the pulp. Pulpitis or inflammation of the pulp may be reversible or irreversible, symptomatic, acute, or asymptomatic, chronic, partial, or total, and the pulp may be infected or sterile. The extent of inflammation, whether partial or total, cannot be determined histologically, and the bacteriologic state, whether the tissue is infected or sterile, cannot be determined except by smear or culture. The only clinical differentiation possible in pulpitis is between the symptomatic and asymptomatic stages of the disease. The sequelae of the various diseases of the pulp are depicted in box 4.2. The clinical classification of pulpal diseases is based primarily on symptoms. No correlation exists between histopathologic findings and the existing symptoms. The value of the clinical classification lies in its use by the clinician to determine the appropriate care and treatment. The endodontic. Figure 4.12 discoloration in a maxillary central incisor with a history of trauma. Grossman binder. In 58 October 11, 2020, 12:50 and 3 seconds. Chapter 4 Diseases of the Dental Pulp 59. Prognosis, and probably the restorative needs of the tooth. The demarcation between irritation of the pulp leading to productive stimulation of secondary dentin formation and that leading to pulpitis is indistinct. Clinical note. The reaction of the pulp depends not only on the degree of irritation but also on the individual makeup and resistance of the pulp tissue to injury. In one case, a slight degree of irritation produces a symptomless productive reaction of the pulp, in another it produces hyperemia, and in still another, acute pulpitis may result. The diseases of the pulp may be clinically classified as given in box 4.3. A reversible pulpitis. Definition: reversible pulpitis is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli in which the pulp is capable of returning to the uninflamed state following removal of the stimuli. Types: acute reversible pulpitis, the pain has been present for a short time, example a few hours or days, however, it immediately ceases on removal of the aggravating stimuli. Chronic reversible pulpitis, the pain has been present for a long time, example months, however, it immediately ceases on removal of the aggravating stimuli. Cause: reversible pulpitis may be caused by any agent that is capable of injuring the pulp. Specifically, the cause may be any of the following: trauma, as from a blow or from a disturbed occlusal relationship; thermal shock, as from preparing a cavity with a dull burr or keeping the burr in contact with the tooth for too long, or as from overheating during polishing a filling. Clinical classification of the diseases of the pulp. 1. Inflammatory diseases of the dental pulp. A. Reversible pulpitis. I. Acute reversible pulpitis. 2. Chronic reversible pulpitis. B. Irreversible pulpitis. I. Symptomatic irreversible pulpitis, previously known as acute irreversible pulpitis. 2. Asymptomatic irreversible pulpitis, previously known as chronic irreversible pulpitis. 3. Chronic hyperplastic pulpitis, also known as pulpal hyperplasia. 4. Internal resorption. 2. Pulp degeneration. A. Calcific degeneration, radiographic diagnosis. B. Fibrous degeneration. 3. Pulp necrosis. A. Pulp necrobiosis, part of pulp is necrotic and infected, the rest is irreversibly inflamed. B. Pulp necrosis with no signs of infection. C. Necrotic and infected pulp. Box 4.3. Sequelae of pulpal diseases. Prognosis, and probably the restorative needs of the tooth. The clinical note. The reaction of the pulp depends not only on the degree of irritation but also on the individual makeup and resistance of the pulp tissue to injury. In one case, a slight degree of irritation produces a symptomless productive reaction of the pulp, in another it produces hyperemia, and in still another, acute pulpitis may result. The diseases of the pulp may be clinically classified as given in box 4.3. A reversible pulpitis. Definition: reversible pulpitis is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli in which the pulp is capable of returning to the uninflamed state following removal of the stimuli. Types: acute reversible pulpitis, the pain has been present for a short time, example a few hours or days, however, it immediately ceases on removal of the aggravating stimuli. Chronic reversible pulpitis, the pain has been present for a long time, example months, however, it immediately ceases on removal of the aggravating stimuli. Cause: reversible pulpitis may be caused by any agent that is capable of injuring the pulp. Specifically, the cause may be any of the following: trauma, as from a blow or from a disturbed occlusal relationship; thermal shock, as from preparing a cavity with a dull burr or keeping the burr in contact with the tooth for too long, or as from overheating during polishing a filling. Clinical classification of the diseases of the pulp. 1. Inflammatory diseases of the dental pulp. A. Reversible pulpitis. I. Acute reversible pulpitis. 2. Chronic reversible pulpitis. B. Irreversible pulpitis. I. Symptomatic irreversible pulpitis, previously known as acute irreversible pulpitis. 2. Asymptomatic irreversible pulpitis, previously known as chronic irreversible pulpitis. 3. Chronic hyperplastic pulpitis, also known as pulpal hyperplasia. 4. Internal resorption. 2. Pulp degeneration. A. Calcific degeneration, radiographic diagnosis. B. Fibrous degeneration. 3. Pulp necrosis. A. Pulp necrobiosis, part of pulp is necrotic and infected, the rest is irreversibly inflamed. B. Pulp necrosis with no signs of infection. C. Necrotic and infected pulp. Box 4.3. Sequelae of pulpal diseases. Ischemia induced by traumatic injuries. Stimuli causing degenerative pulpal changes. Noxious stimuli causing inflammation. Chronic hyperplastic pulpitis. Symptomatic irreversible pulpitis. Asymptomatic irreversible pulpitis. Internal resorption. Pulpal necrosis, calcific degeneration / calcific metamorphosis. Irreversible pulpitis. Reversible pulpitis. Normal pulp. Box 4.2. Grossman binder. In 59 October 11, 2020, 12:50 and 3 seconds. 60 Grossman's endodontic practice. Excessive dehydration of a cavity or irritation of exposed dentin at the neck of a tooth. Placement of a fresh amalgam filling in contact with, or occluding, a cast restoration. Chemical stimulus, as from sweet or sour foodstuffs or from irritation of a filling, or bacteria, as from caries following insertion of a restoration. Patients often complain of mild sensitivity to temperature changes, especially cold. Such sensitivity may last 2 to 3 days or a week, or even longer, but it gradually subsides. This sensitivity is symptomatic of reversible pulpitis. Circulatory disturbances, such as those accompanying menstruation or pregnancy, may also result in a transient periodic hyperemia. Local vascular congestion associated with common cold or with sinus disease can cause a generalized transient hyperemia of the pulp of the maxillary posterior teeth. The irritant that causes hyperemia or mild inflammation in one pulp may produce secondary dentin in another if the irritant is mild enough or if the pulp is vigorous enough to protect itself. Symptoms. Symptomatic reversible pulpitis is characterized by short, sharp pain lasting for a moment. This pain is always specific to a stimulus. The pain is instantly relieved on removal of the stimulus. It is more often brought on by cold than by hot food or beverages and by cold air. It does not occur spontaneously and does not continue when the cause has been removed. The clinical difference between reversible and irreversible pulpitis is quantitative. The pain of irreversible pulpitis is more severe and lasts longer. In reversible pulpitis, the cause of the pain is generally traceable to a stimulus, such as cold water or a draft of air, whereas in irreversible pulpitis, the pain may come without any apparent stimulus. Fig 4.13. Diagnosis. Diagnosis is by a study of the patient's symptoms and by clinical tests. The pain is sharp, lasts but a few seconds, and generally disappears when the stimulus is removed. Cold, sweet, or sour usually causes it. Pain may become chronic. Although each paroxysm may be of short duration, the paroxysms may continue for weeks or even months. The pulp may recover completely, or the pain may last longer each time, and intervals of relief may become shorter, until the pulp finally succumbs. Because the pulp is sensitive to temperature changes, particularly cold, application of cold is an excellent method of locating and diagnosing the involved tooth. A tooth with reversible pulpitis reacts normally to percussion, palpation, and mobility, and the periapical tissue is normal on radiographic examination. Differential diagnosis. In reversible pulpitis, the pain is generally transitory, lasting a matter of seconds, whereas in irreversible pulpitis, the pain may last several minutes or longer. The patient's description of the pain, particularly regarding its onset, character, and duration, is often of inestimable help in arriving at a correct differential diagnosis. Thermal tests are useful in locating the affected tooth if unknown. The electric pulp test, using less current than on a control tooth, is an excellent corroborating test. Histopathology. Reversible pulpitis may range from hyperemia to mild to moderate inflammatory changes limited to the area of the involved dentinal tubules, such as dentinal caries. Microscopically, one sees reparative dentin, disruption of the odontoblast layer, dilated blood vessels, extravasation of edema fluid, and presence of immunologically competent chronic inflammatory cells. Although chronic inflammatory cells predominate, one may see acute inflammatory cells. Treatment. The best treatment for reversible pulpitis is prevention. Periodic care to prevent the development of caries, early insertion of a filling if a cavity has developed, desensitization of the necks of teeth where gingival recession is marked, use of a cavity varnish or cement base before insertion of a filling, and care in tooth preparation and polishing are recommended to prevent pulpitis. When reversible pulpitis is present, removal of the noxious stimuli will usually bring the pulp back to a healthy state. Once the symptoms have subsided, the tooth should be tested for vitality to make sure that pulpal necrosis has not occurred. When pain persists despite proper treatment, the pulpal inflammation should be regarded as irreversible, the treatment for which is pulp extirpation. Prognosis. The prognosis for the pulp is favorable if the irritant is removed early enough, otherwise, the condition may develop into irreversible pulpitis. B. Irreversible pulpitis. Definition: irreversible pulpitis is a persistent inflammatory condition of the pulp, symptomatic or asymptomatic in nature with the pulp becoming incapable of healing. Types: asymptomatic irreversible pulpitis, symptomatic irreversible pulpitis. Grossman binder. Inf 60 October 11, 2020, 12:50 and 3 seconds. Chapter 4 Diseases of the Dental Pulp 61. A, B, C, D. Figure 4.13 Upper molar with clinically good amalgam restoration. A. Tooth was symptomatic for biting forces and cold application. B. After amalgam removal. C. After restoration with direct composite and total etch technique. D. Symptomless, vital tooth after 5 years. Courtesy, Njek Opdam, Netherlands. Cause. The most common cause of irreversible pulpitis is bacterial involvement of the pulp through caries, although any clinical factor, chemical, thermal, or mechanical, already mentioned as a cause of pulp disease, may also cause pulpitis. As previously stated, reversible pulpitis may deteriorate into irreversible pulpitis. Symptoms. In the early stages of irreversible pulpitis, a paroxysm of pain may be caused by the following: sudden temperature changes, particularly cold, sweet or acid foodstuffs, and pressure from packing food into a cavity or suction exerted by the tongue or cheek. Symptomatic irreversible pulpitis exhibits pain usually caused by a hot or cold stimulus, or pain that occurs. Grossman binder. Inf 61 October 11, 2020, 12:50 and 4 seconds. 62 Grossman's endodontic practice. Spontaneously. The pain persists for several minutes to hours, lingering after removal of the thermal stimulus. The pain often continues when the cause has been removed, and it may come and go spontaneously, without an apparent cause. The patient may describe the pain as sharp, piercing, or shooting, and it is generally severe. It may be intermittent or continuous, depending on the degree of pulpal involvement and on whether it is related to an external stimulus. The patient may also complain of postural pain, i.e., change of position, bending over or lying down, exacerbates the pain. This is due to the increase in intrapulpal pressure when the patient changes position from a standing posture to a supine, lying down, posture. The patient may also have pain referred to adjacent teeth, to the temple or sinuses when an upper posterior tooth is involved, or to the ear when a lower posterior tooth is affected. In later stages, the pain is more severe and is generally described as boring, gnawing, or throbbing, or as if the tooth was under constant pressure. The pulp need not be macroscopically exposed, but a slight exposure is generally present, or else the pulp is covered with a layer of soft, leathery decay. When no outlet is present, whether because of a covering of decay or a filling or because of food packed into a small exposure in the dentin, pain can be most intense. Patients are often kept awake at night by the pain, nocturnal pain, which continues to be intolerable despite all their efforts at analgesia. Pain is increased by heat and is sometimes relieved by cold, although continued cold may intensify the pain. After exposure and drainage of the pulp, pain may be slight, manifesting itself as a dull consciousness, or may be entirely absent. Pain can return if food packs into the cavity or underneath a leaky filling. It may not be as intense because of degeneration of the superficial nerve fibers. Apical periodontitis is absent, except in the later stages, when inflammation or infection extends to the periodontal ligament. Diagnosis. Inspection generally discloses a deep cavity extending to the pulp or decay under a filling, Fig 4.14. The pulp may already be exposed. On gaining access to the exposure, one may see a grayish, scum-like layer over the exposed pulp and the surrounding dentin. This layer is composed of food debris, degenerated polymorphonuclear leukocytes, microorganisms, and blood cells. The surface of the pulp is eroded. An odor of decomposition is frequently present in this area. Probing into the area is not painful to the patient until the deeper areas of the pulp are reached. At this level, both pain and hemorrhage may occur. If the pulp is not exposed by the carious process, a drop of pus may be expressed when one gains access to the pulp chamber. Radiographic examination may not show anything of significance that is not already known clinically. It may disclose an interproximal cavity not seen visually or may suggest involvement of a pulp horn, Fig 4.15. A radiograph may also show exposure of the pulp, caries under a filling, or a deep cavity or filling threatening the integrity of the pulp. In the early stages of irreversible pulpitis, the thermal test may elicit pain that persists after removal of the thermal stimulus. In the late stages, when the pulp is exposed, it may respond normally to a thermal stimulus, but generally it reacts feebly to heat and cold. The electric pulp test induces a response with a marked variation in current from the normal. Results of examination for mobility and percussion and palpation tests are negative. Figure 4.14 Fractured restoration with secondary caries showing clinical signs of irreversible pulpitis. Figure 4.15 Radiographic evidence of decay involving the distal pulp horn in a mandibular molar with clinical signs of irreversible pulpitis. Note the lack of any periradicular radiographic changes. Grossman binder. In 62 October 11, 2020, 12:50 and 4 seconds. Chapter 4 Diseases of the Dental Pulp 63. Differential Diagnosis. One must distinguish between reversible and irreversible pulpitis. Clinical note. In reversible pulpitis, the pain produced by a thermal stimulus disappears as soon as the stimulus is removed, whereas in irreversible pulpitis, the pain lingers after the stimulus is removed, or it can occur spontaneously. In the asymptomatic stage of irreversible pulpitis, the exposed pulp exhibits little or no pain, except when food is packed into the cavity. More current is required to elicit a response to the electric pulp test than in a control tooth. In the early symptomatic stage, less current than what is normal is needed to elicit a response to the electric pulp tester, and the pulp is often abnormally responsive to a cold stimulus. The induced or spontaneous pain that occurs is sharp, piercing, and readily identified with a specific tooth. Other symptoms may develop, such as diffuse, dull, constant pain, characterized by throbbing and gnawing, and the tooth may respond abnormally and severely to heat. This response is generally indicative of a later stage of irreversible pulpitis. In this stage of irreversible pulpitis, the symptoms may simulate those of an acute alveolar abscess. Such an abscess, however, causes at least some of the following symptoms, which help to differentiate it from irreversible pulpitis: swelling, tenderness on palpation, tenderness on percussion, mobility of the tooth, and lack of response to pulp vitality tests. In addition, the patient may have symptoms of systemic toxicity such as fever and nausea. The pain of pulpitis is easy to localize by the patient at the onset. Once discomfort increases, the patient loses the ability to identify a particular tooth in the quadrant. A previous history of pain may help one to localize the origin of the pulpalgia. When pulpal pain is difficult to localize, the application of heat with a consequent abnormal response is indicative of irreversible pulpitis in that tooth. Histopathology. This disorder has chronic and acute inflammatory stages in the pulp. Irreversible pulpitis may be caused by a long-standing noxious stimulus such as caries. As it penetrates the dentin, caries causes a chronic inflammatory response previously discussed with regard to reversible pulpitis. If the caries is not removed, the inflammatory changes in the pulp will increase in severity as the decay approaches the pulp. The post-capillary venules become congested, as previously discussed, and affect the circulation within the pulp, causing pathologic changes such as necrosis. These necrotic areas attract polymorphonuclear leukocytes by chemotaxis and start an acute inflammatory reaction. Phagocytosis by the polymorphonuclear leukocytes of the area of necrosis ensues. After phagocytosis, the polymorphonuclear leukocytes, which have a short lifespan, die and release lysosomal enzymes. The lysosomal enzymes lyse some of the pulp stroma and, together with the cellular debris of the dead polymorphonuclear leukocytes, form a purulent exudate, pus. This inflammatory reaction produces microabscesses, acute pulpitis. The pulp, trying to protect itself, walls off the areas of the microabscesses with fibrous connective tissue. Microscopically, one sees the area of the abscess and a zone of necrotic tissue, with microorganisms present in the late carious state, along with lymphocytes, plasma cells, and macrophages. No microorganisms are found in the center of the abscess because of the phagocytic activity of the polymorphonuclear leukocytes. If the carious process continues to advance and penetrates the pulp, the histologic picture changes. One then sees an area of ulceration, chronic ulcerative pulpitis, that drains through the carious exposure into the oral cavity and reduces the intrapulpal pressure and, therefore, the pain. Histologically, one sees an area of necrotic tissue, a zone of infiltration by polymorphonuclear leukocytes, and a zone of proliferating fibroblasts forming the wall of the lesion, where calcific masses may be present. The areas beyond the abscess or the ulceration may be normal or may undergo inflammatory changes. Irreversible pulpitis progresses to necrosis, as discussed later in this chapter. Treatment. Treatment consists of complete removal of the pulp or pulpectomy. In posterior teeth, in which time is a factor, the removal of the coronal pulp or pulpotomy should be performed as an emergency procedure. Surgical removal should be considered if the tooth is not restorable. Prognosis. The prognosis of the tooth is favorable if the pulp is removed and if the tooth undergoes proper endodontic therapy and an appropriate postendodontic restoration. The characteristic features distinguishing reversible and irreversible pulpitis are given in Table 4.1. See chronic hyperplastic pulpitis. Definition: chronic hyperplastic pulpitis, also known as pulpal hyperplasia or pulp polyp, is a productive pulpal inflammation due to an extensive carious exposure of a young pulp. This disorder is characterized by the development of granulation tissue, covered at times with epithelium and resulting from long-standing, low-grade irritation. Cause: slow, progressive carious exposure of the pulp is the cause. For the development of hyperplastic pulpitis, a large, open cavity, a young, resistant pulp, and a chronic, low-grade Grossman binder. Inp 63 October 11, 2020, 12:50 and 4 seconds. 64 Grossman's endodontic practice. Stimulus are necessary. Mechanical irritation from chewing and bacterial infection often provide the stimulus. Symptoms. Chronic hyperplastic pulpitis is symptomless, except during mastication, when pressure of the food bolus may cause discomfort. Diagnosis. This disorder is generally seen only in the teeth of children and young adults. The appearance of the polypoid tissue is clinically characteristic. A fleshy, reddish pulpal mass fills most of the pulp chamber or cavity or even extends beyond the confines of the tooth, Fig 4.16a and 4.16b. At times, the mass is large enough to interfere with comfortable closure of the teeth, although in the early stages of development, it may be the size of a pin. Polypoid tissue is less sensitive than normal pulp tissue and more sensitive than gingival tissue. Cutting of this tissue produces no pain, but pressure thereby transmitted to the apical end of the pulp does cause pain. This tissue bleeds easily because of a rich network of blood vessels. If the hyperplastic pulp tissue extends beyond the cavity of a tooth, it may appear as if the gum tissue is growing into the cavity. To differentiate a pulp polyp from proliferating gingival tissue, one should raise and trace the stalk of the tissue back to its origin, the pulp chamber. It should not be difficult to diagnose chronic hyperplastic pulpitis by clinical examination alone. The hyperplastic pulp tissue in the pulp chamber or cavity of a tooth is characteristic in appearance. Radiographs generally show a large, open cavity with direct access to the pulp chamber, Fig 4.16c. The tooth may respond feebly or not at all to the thermal test, unless one uses extreme cold, as from an ethyl chloride spray. More current than what is normal may be required to elicit a response by means of the electric pulp tester. Differential diagnosis. The appearance of hyperplastic pulpitis is characteristic and should be easily recognized. The disorder must be distinguished from proliferating gingival tissue. Histopathology. Histopathologically, the surface of the pulp polyp is usually covered by stratified squamous epithelium. The pulp polyps of deciduous teeth are more likely to be covered with stratified squamous epithelium than those of permanent teeth. Such epithelium may be derived from the gingiva or from freshly desquamated epithelial cells of the mucosa or tongue. Table 4.1 Characteristic distinguishing features of pulpal diseases. Features: reversible pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis. Description: a pulpal inflammation reversible in nature, which is commonly induced by dental caries and operative procedures, in which the patient responds to thermal or osmotic stimuli, but the symptoms disappear when the etiology is eliminated. A pulpal inflammation irreversible in nature, which is usually caused by deep dental caries or restorations. Spontaneous pain may occur or be precipitated by thermal or other stimuli. The pain is lingering and lasts for several minutes to hours. A pulpal inflammation irreversible in nature, which is usually caused by deep dental caries or restorations. The tooth is asymptomatic and if left untreated will become symptomatic irreversible pulpitis, or the pulp might become necrotic. Clinical features: symptomatic in nature. Nature of pain is moderate to sharp in response to thermal, sweet, or sour stimuli and is specific in response to stimuli, sharp and short in duration, and relieved on removal of stimuli. Symptomatic in nature. Nature of pain is sharp, exaggerated, painful in response to thermal stimulus and is either one or a combination of the following symptoms: spontaneous, continuous, lingering, nocturnal. Asymptomatic in nature. Key finding: diagnosis. Nature of pain: sharp, short pain that is relieved immediately on removal of stimuli. Nature of pain: dull pain that lingers even after the removal of the stimuli. Patient is asymptomatic. Pain on percussion: negative, negative, negative. Radiographic features: radiographs show no periradicular changes. Radiographs show no periradicular changes. Radiographs show no periradicular changes. Treatment: removal of causative agent, pulpectomy. Pulpectomy. Grossman binder. Inf 64 October 11, 2020, 12:50 and 4 seconds. Chapter 4 Diseases of the Dental Pulp 65. The tissue in the pulp chamber is often transformed into granulation tissue, which projects from the pulp into the carious lesion. The granulation tissue is a young, vascular connective tissue containing polymorphonuclear neutrophils, lymphocytes, and plasma cells. The pulp tissue is chronically inflamed. Nerve fibers may be found in the epithelial layer. Treatment. Treatment should be directed toward elimination of the polypoid tissue followed by extirpation of the pulp, provided the tooth can be restored. When the hyperplastic pulpal mass has been removed with a periodontal curette or spoon excavator, the bleeding can be controlled with pressure. The pulp tissue of the chamber is then completely removed, and a temporary dressing is sealed in contact with the radicular pulp tissue. The radicular pulp is extirpated at a later visit. If time permits, the entire procedure, pulpectomy, can be completed in a single visit. Prognosis. The prognosis for the pulp is unfavorable. The prognosis for the tooth is favorable after endodontic treatment and adequate restoration. Internal resorption. Definition: resorption is defined as a condition associated with either a physiologic or a pathologic process resulting in loss of dentin, cementum, or bone. Internal resorption is an idiopathic slow or fast progressive resorptive process occurring in the dentin of the pulp chamber or in the root canals of the teeth. Cause. The cause of internal resorption is not known, but such patients often have a history of trauma. Symptoms. Internal resorption in the root of a tooth is asymptomatic. In the crown of the tooth, internal resorption may be manifested as a reddish area called pink spot. This reddish area represents the granulation tissue showing through the resorbed area of the crown. Diagnosis. Internal resorption may affect either the crown, Fig 4.17, or the root, Fig 4.18, of the tooth, or it may be extensive enough to involve both, Fig 4.19. It may be a slow, progressive, intermittent process extending over 1 or 2 years. It may develop rapidly and may perforate the tooth within a matter of months. Although any tooth in the mouth can be involved, those most readily recognized are the maxillary anterior teeth. Usually, internal resorption is diagnosed during routine radiographic examination. The appearance of the pink spot occurs late in the resorptive process, when the integrity of the crown has been compromised. The radiograph usually shows a change in the appearance of the wall in the root canal or pulp chamber, with the round or ovoid radiolucent area. Differential diagnosis. When internal resorption progresses into the periodontal space, a perforation of the root occurs. It is difficult to differentiate from external resorption. In internal resorption, the resorptive defect is more extensive in the pulpal wall than on the root surface. This defect usually is recognized by means of a radiograph. Histopathology. Unlike caries, the internal resorption is the result of osteoclastic activity. The resorptive process is characterized by lacunae, which may be filled in by osteoid tissue. The osteoid tissue may be regarded as an attempt at repair. The presence of granulation tissue accounts for profuse bleeding when A, B, C. Figure 4.16, A and B, chronic hyperplastic pulpitis with a characteristic polypoid tissue growth. C, radiographic appearance of a mandibular molar exhibiting chronic hyperplastic pulpitis. Grossman binder. In 65 October 11, 2020, 12:50 and 4 seconds. 66 Grossman's endodontic practice. The pulp is removed. Multinucleated giant cells or dentinoclasts are present. The pulp usually is chronically inflamed. Metaplasia of the pulp, i.e., transformation to another type of tissue such as bone or cementum, sometimes occurs. Treatment. Extirpation of the pulp stops the internal resorptive process. Routine endodontic treatment is indicated, but obturation of the defect requires a special effort, preferably with the plasticized gutta-percha method. In many patients, however, the condition progresses unobserved because it is painless, until the root is perforated. In such a case, mineral trioxide aggregate, MTA, is recommended to repair the defect. When repair has been completed, the canal with its defect is obturated with plasticized gutta-percha, Fig 4.20. Prognosis. The prognosis is best before perforation of the root or crown occurs. In the event of a root, crown perforation, the Figure 4.19, A and B, radiographic image of maxillary central incisors showing an internal resorptive defect with perforation of the root margin. A. B. A. B. Figure 4.17, A, pink spot indicative of an internal resorptive defect seen in the palatal aspect of the crown of the maxillary central incisor. B, radiographic image of the same tooth showing an internal resorptive defect with intact crown margins. Figure 4.18, an extracted tooth showing evidence of internal resorption causing root perforation. Courtesy, Martin S. Spiller, USA. Grossman binder. Inp 66 October 11, 2020, 12:50 and 5 seconds. Chapter 4, Diseases of the Dental Pulp. 67. Prognosis is guarded and depends on the access to the perforation that permits surgical repair. Refer to Chapter 22 for surgical management of internal resorption. 2. Pulp degeneration. Although degeneration of the pulp, as such, is seldom recognized clinically, the types of pulp degeneration should be included in a description of diseases of the pulp. Degeneration is generally present in the teeth of older people. It may also be the result of persistent, mild irritation in teeth of younger people, as in calcific degeneration of the pulp. It is not necessarily related to infection or caries, although a cavity or filling may be present in the affected tooth. The early stage of pulp degeneration does not usually cause definite clinical symptoms. The tooth is not discolored, and the pulp may react normally to electric and thermal tests. As degeneration of the pulp progresses, the tooth may become discolored, and the pulp will not respond to stimulation. The specific types of pulp degeneration are discussed in the following text. A. Calcific degeneration. In calcific degeneration, part of the pulp tissue is replaced by calcific material, i.e., pulp stones, or denticles. Calcification may occur either within the pulp chamber or within the root canal, but it is generally present in the pulp chamber, Fig 4.21. The calcified material has a laminated structure, like the skin of an onion, and lies unattached within the body of the pulp. A denticle or pulp stone may become large enough to give an impression of the pulp cavity when the calcified mass is removed. In another type of calcification, the calcified material is attached to the wall of the pulp cavity and is an integral part of it. It is not always possible to distinguish one type from another on a radiograph. It is estimated that pulp stones are present in more than 60% of adult teeth. They are considered to be harmless concretions, although referred pain in a few patients has been ascribed to the presence of these calcifications in the pulp. The calcific degeneration of the complete pulp space. When it occurs as a sequela to a traumatic injury is known as calcific metamorphosis. This is a type of a pulpal response to trauma characterized by rapid deposition of hard tissue within the canal space. Such teeth usually remain clinically. A. B. Figure 4.20, A. Internal resorption in a maxillary incisor. B. Postoperative view. Courtesy, Clifford Ruddle, USA. A. B. Figure 4.21, A. Radiographic appearance of a maxillary molar. 68. Grossman's endodontic practice. Asymptomatic and may exhibit discoloration of the clinical crown. Obliteration of the pulp space is evident radiographically as an intracanal radio opacity similar to the surrounding dentin, Fig 4.22. Clinical note. Clinical management of a case of calcific metamorphosis is given below: asymptomatic tooth, aesthetic management of the discolored tooth with a full coverage restoration or laminate restoration. Symptomatic tooth, endodontic therapy using a microsurgical retrograde approach is recommended. Endodontic therapy is not recommended unless the tooth is symptomatic. B. Fibrous degeneration. This form of degeneration of the pulp is characterized by replacement of the cellular elements by fibrous connective tissue. On removal from the root canal, such a pulp has the characteristic appearance of a leathery fiber, Fig 4.23. This disorder causes no distinguishing symptoms to aid in the clinical diagnosis. 3. Necrosis of pulp. Necrosis is death of the pulp. It may be partial or total, depending on whether part of or the entire pulp is involved. Necrosis, although a sequel to inflammation, can also occur following a traumatic injury in which the pulp is destroyed before an inflammatory reaction takes place. As a result, an ischemic infarction can develop and may cause a dry gangrenous necrotic pulp. Types. A. Pulp necrobiosis. A tooth with necrobiosis has both inflamed, acute irreversible pulpitis, and necrotic, usually infected, pulp tissue. Grossman suggested the term necrobiosis because it accurately indicates the condition, with necro indicating necrosis and bio indicating the presence of vital tissue. The pulp sensibility tests usually do not correlate with the patient's symptoms. The key diagnostic feature would be that the patient would report with mixed symptoms, i.e., symptoms of pulpitis and an infected root canal system at the same time. B. Pulp necrosis with no signs of infection. In cases of necrosis without infection, there will be no periapical tissue response. Hence, there will be no apical periodontitis. The key diagnostic feature would be that there would be no symptoms, no response to pulp sensibility tests, and no other abnormal findings. C. Necrotic and infected pulp. When a pulp necroses as a result of bacterial invasion of the tooth, it will become infected over time. The patient would report with no pulp-related symptoms, i.e., no thermal sensitivity, maybe no symptoms at all. Any symptoms will be from the periapical tissues, hence, symptoms depend on the periapical status. The key diagnostic feature would be that there would be no response to pulp sensibility tests and there will be a periapical radiolucency. Figure 4.22 Calcific Metamorphosis, complete obliteration of the pulp space seen in this maxillary central incisor with a history of trauma. A, B, C. Figure 4.23, A, intact pulp after extirpation from the canal. B, extirpated pulp showing coronal calcification with an intact uninflamed radicular pulp. Courtesy, Jason Hales, USA. C, extirpated pulp showing calcific degeneration in the coronal third with fibrous degeneration in the remaining radicular pulp. Courtesy, Hemlata India. Grossman binder. Inp 68 October 11, 2020, 12:50 and 6 seconds. Chapter 4 Diseases of the dental pulp. 69. Cause. Necrosis of the pulp can be caused by any noxious insult injurious to the pulp, such as bacteria, trauma, and chemical irritation. Symptoms. An otherwise normal tooth with a necrotic pulp causes no painful symptoms. Frequently, discoloration of the tooth is the first indication that the pulp is dead. The dull or opaque appearance of the crown may be merely due to a lack of normal translucency. At other times, however, the tooth may have a definite grayish or brownish discoloration and may lack its usual brilliance and luster. The presence of a necrotic pulp may be discovered only by chance because such a tooth is asymptomatic, and the radiograph is non-diagnostic. Teeth with partial necrosis can respond to thermal changes, owing to the presence of vital nerve fibers passing through the adjacent inflamed tissue. Diagnosis. Radiographs generally show a large cavity or filling, an open approach to the root canal, and a thickening of the periodontal ligament. Some teeth have neither a cavity nor a filling, and the pulp has died as a result of trauma. A few patients have a history of severe pain lasting from a few minutes to a few hours, followed by complete and sudden cessation of pain. In other cases, the patient is unaware that the pulp has died slowly and silently, without causing symptoms. A tooth with a necrotic pulp does not respond to cold, the electric pulp test, or the test cavity. In rare cases, however, a minimal response to the maximum current of an electric pulp tester occurs when the electric current is conducted through the moisture present in a root canal following liquefaction necrosis to neighboring vital tissue. In other patients, a few apical nerve fibers survive and respond similarly. Nerve fibers are resistant to inflammatory changes. A correlation of cold and electric tests and a history of pain, in conjunction with a thorough clinical examination, should establish a correct diagnosis. Treatment. Treatment consists of complete removal of pulp, pulpectomy, and obturation of the root canals. Histopathology. Histopathologically, necrosis is of two general types. One, coagulation necrosis results in the soluble portion of the tissue being precipitated or converted into a solid material. Caseation necrosis is a form of coagulation necrosis in which the tissue is converted into a cheesy mass consisting chiefly of coagulated proteins, fats, and water. 2. Liquefaction necrosis results when proteolytic enzymes convert the tissue into a softened mass, a liquid, or amorphous debris. The end products of pulp decomposition are those of protein decomposition, namely, hydrogen sulfide, ammonia, fatty substances, indican, tomains, water, and carbon dioxide. The intermediate products, such as indole, scatole, putrescine, and cadaverine, contribute to the unpleasant odor sometimes emanating from a root canal. Necrotic pulp tissue, cellular debris, and microorganisms may be seen in the pulp cavity. The periapical tissue may be normal or slight evidence of inflammation of the apical peri. Odontal ligament may be present. Prognosis. The prognosis for the tooth is favorable if proper endodontic therapy is instituted. Bibliography. 1. Adrian, J.C., E.T.
बोतल अभी निकालिए जो इतना क्या रखा लिया भैया इधर के निकली पीछे तो देखो